Thank you for joining us. My name is Theron Steinke, and I am honored to introduce you to our team of clinical educators and local prosthetists and orthotists. It is our firm belief that patients living with limb loss receive the best outcome possible when we take the team approach to their care. The relationship between the prosthetist, therapist, physician, and other treating medical professionals starts and ends with open communication and education. We learn just as much from you as we hope that you learn from us, and it is our goal to make these presentations a conversation, not a lecture. We sincerely thank you for your support and devotion to this specialized patient population.
Hi, my name is Renée Veld, and I'm a physical therapist. I work for an orthotics and prosthetics company in the Midwest. I do a lot of education presentations to both practicing therapists and students, as well as consulting with our practitioners for patients with lower extremity amputations. I worked for over 20 years as a physical therapist at a level 1 trauma hospital locally, mostly in the outpatient department, treating patients with amputations as frequently as possible. I also taught in a local DPT university program for 14 years, teaching content on wound care and amputations, as well as serving as the director of clinical education. Now, my passion is continuing with education. I like to help as many people with amputations as possible by training therapists. I enjoy training therapists who have been therapists for a long time, who treat amputees routinely, as well as helping people who don't treat amputees very often to feel comfortable with this content. I want them to feel like they have the words to ask the right questions of their local practitioners for best patient outcome. Hi everyone, this in-service is about common suspension techniques for lower extremity prostheses. Here are the goals. We're going to talk a little bit about definitions. This is kind of Suspension System 101 to make sure that you're up to date with the typical processes and suspensions that you're going to see from your local company. Here are course objectives that you can use as reference as you're going back over this handout. So this is in order of start to finish, closest to the skin toward outside of the skin. So I'm going to start with something called a sheath, and this may or may not be something with which you're familiar. Prosthetists also call it a liner, which kind of makes me laugh, but it's a liner inside the liner, hence the name. Not all of your patients are going to need this or be appropriate for this, but I think it's really important for therapists to know that it exists. It took me a long time practicing before I knew about these. It's the thickness of pantyhose, and it's very helpful if somebody tends to sweat a fair amount inside their liner, or if they have any other kind of skin irritation and they don't tolerate the gel or the silicone really well. These are, again, not very often seen, but you can ask for this. The prosthetist isn't naturally going to do a liner or a sheath for every patient. Great conversation to have with your prosthetist. The tip that I have for these for donning is, as the slide says, you want it to be smooth against your skin. The other sneaky trick is that you don't want it to come above the top of the liner. You want it to be, a little bit below, maybe an inch below the liner. The liner needs to have good purchase on the skin. So if they're not too irritated by doing that, then have it just be a little shorter. And the prosthetist will cut the liner at the appropriate length, which is, you've got a little bit more give for the transtib patients than you do for the transfem patients. So that's what a liner is. All right, moving on to liners. So the liners are the primary interface between the patient's skin and the socket. So this is kind of where the action happens. There are lots of different kinds of liners. I didn't realize that for a long time. I thought, oh, there's a couple out there, and I didn't know what would make a prosthetist choose one over another. I'm understanding that better now. But as a therapist, don't worry about it too much. Just trust that the prosthetist is going to choose correctly. So some of them have gel on the inside of them. Some of them are lined with silicone. And there are also liners made out of urethane for some of the higher level suspension systems like elevated vacuum. The other thing to know in general about liners is there are a few different general kinds based on the suspension system. So we're going to touch on each one of these three kinds of liners that are listed on this slide. So there's a liner that's called a locking liner, a liner that's called a cushion liner. That's what this one is it doesn't have any attachment on the end of it. And there's a liner that's called a seal-in liner. Again, there are several brands for each one of these. Don't get too hung up on this actual definition, but this is the language the prosthetist will use. And if you want to better communicate with them and understanding what they're doing, then I think it's helpful to understand this language in general terms. So for donning, so you have the patient turn the liner completely inside out, which we have people doing this with all kinds of manual dexterity issues, and it's not as easy as it can look, right? So yeah, I just had to fight with that one. Turn it in completely inside out. And then you want to press the end of the leg into the end of the liner. We really want to avoid a pocket of air. Any pocket of air is going to create some extra pull and you're going to get skin breakdown, no question about that. So it goes flush against the end of the leg and then the liner is rolled onto the limb all the way. Roll, don't pull is the instruction you can give to your patients. How far the liner comes up the leg is obviously dependent on the patient, how long their residual limb is, what kind of suspension system they have. You might find that you're spending an entire therapy session with donning. So remember that patients need to have good sitting balance to be able to lean over, especially trans-tib patients. They need to reach kind of far to roll these liners on. Helping them to manage that and also having your OT buddies, maybe this is a reason for them to see the patient. OTs can be working on donning. This is a wonderful task for them. PTs are working on early gait. There's a great relationship there and patients can get a little bit better therapy. So those are the general tips for donning. Roll, don't pull. Now, socks. So in all of my teaching for DPT students, I've told them that the answer to 85% of their questions is socks. Right? So we joke that the exam is going to be all about socks. I always put a question on the exam about socks as a gimme. They ought to know by now that you can solve a lot of problem with socks. So the general concept is the patient will get socks of different thicknesses. Talk to your local practitioner about the kind of socks they use. These are the ones that our company uses. So there are 1-ply socks, and that's the foundation. You add 1 ply at a time. There are 3-ply socks, that's the yellow stitching, and there are 5-ply socks, that's the green stitching. When I worked regularly in my hospital outpatient clinic, I always had a supply of 2-ply socks. I never knew when somebody was going to forget their socks and need to add one during the course of a therapy treatment, which honestly happens quite a lot. So let's not forget that this is where it's at. Your patient should have gotten these socks when they got their leg delivered. So our company gives two or three, I think, of the 3s and 5s and 6 of the singles. Train your patients to bring a bag of all of this stuff to every therapy session, because especially early on, you're going to need to adjust socks. And I've also, as I've spent time teaching people how to roll the liner on their leg, I've spent a lot of time instructing in sock management. Our prosthetists are also teaching sock management. Don't you think they're not? However, think about all of the information that is given to a patient on the day of delivery. It's a lot of information. So even if they get a handout about sock management, I don't think they really internalize what it means until they have to do it. So using some of your therapy sessions to work on this, I think, is really important. And you'll note too on the slide that the number of socks needed might vary from in the time of day, right? In the morning they need fewer, by the afternoon they need more socks, and then over the course of time the shape and volume of their limb, it will stabilize. So that takes a little bit of time for that to happen. I've got a little bit later in the presentation a little bit more about sock management in case that's a new concept to you. So, donning, socks always go over the liner. The sheath or liner is the only thing that goes under the liner next to the patient's skin. I can't tell you how many patients I've had who come in to see me. They got their leg a day before. They proudly walk in. They have a sock inside the liner. Talk about wound setup, right? So you're going to get shear and friction, moisture. It's bad. It's a bad recipe. So the sock always goes over. And in a lot of cases, depending on the suspension system, you might have some length of the liner sticking out over the top of the sock. The whole goal here is for the leg to feel snug. There shouldn't be any wrinkles. Teaching the patient to lean over and feel the end of the sock to make sure it's all the way flush to the liner is also a really helpful thing to work on in therapy. If you look at the picture, you'll see a sock hung up on a pin. So that's also a no-no. People need to reach down and feel and make sure that the sock is in the right place. So how do you know how many ply socks to don? I mentioned this already. We're going to come back to that topic for those of you who aren't sure or aren't sure how to instruct your patients in that. Okay, now the socket. So this is the thing that goes over the liner and over the socks if the patient needs socks. So this is the part of the prosthesis that holds the whole thing together. These are custom made to the patient. They should fit very well. If they don't fit very well, pressure points, right? You might have breakdown, all kinds of issues, certainly pain. This is another great reason to have a conversation with the prosthetist who made the leg. Hey, the socket doesn't seem to be fitting well. Could you take a look at it when the patient comes in to see you for a follow-up? Prosthetists can modify sockets. So I mentioned that this is custom, and it really doesn't, this particular final laminated version of a socket, you can't really do a lot of heat molding like you can on some of the earlier versions of a socket. But what they can do is add padding inside the socket. So for example, they might pad on either side of the tibial crest to offload that and to even out the pressure all the way around. We're looking for total surface bearing for the vast majority of sockets. That's always the goal. A prosthetist can pad a few times before a new socket is warranted. And from a sock perspective, if the patient's wearing at least 10 ply of sock, it's time to talk to the prosthetist about possibly either padding or a new socket, depending on how much padding is already in there. If the patient is ready for a new socket, that does require a physician's order and insurance approval, and we as therapists can help with that. Our documentation can also help with that. In the assessment, we should be saying, this socket doesn't appear to be fitting anymore because of this, this, and this. Patient has pain with ambulation. We've added socks. It's not resolving the issue. And it's time potentially for a new socket, and then you refer back to the prosthetist. So I think that's really important for our documentation to support what the prosthetist is doing and what the patient needs. Okay, now that's all the stuff that leads up to suspension. Now we'll talk specifically about suspension system. So again, it's pretty straightforward. Suspension system is the term used for how a prosthesis is held onto the body. If you are familiar with K levels, which talk about different levels of mobility, suspension systems aren't directly linked to K levels. There are suspension systems that might be more appropriate for someone at a lower level of mobility, or early on in their rehab, they start with one suspension system, then they work themselves out of that and they're appropriate for another suspension system. So I'm not going to cover elevated vacuum today. That's a pretty high level suspension system, but that's something your patient doesn't get to right out of the gate either. Usually if I have a patient who goes from one suspension system to elevated vacuum, I never see them again as a therapist because they're fine. They're off walking in the community, they're back to work, they're doing everything they want to do. Okay, so we're going to start with transtibial. You'll see on the left of your slide, each side has all the pieces and parts that go with this particular suspension system, just to make sure that you're putting it all together. So we'll talk first about suction. At the company where I work, suction is the majority of folks in their first prosthesis for the transtib level. So you start with a liner. There's a one-way valve at the bottom of the socket. This particular socket is the wrong one, but I just picked it up because it was handy to show you. So there's a one-way valve. This and the patient's leg is pushed into the socket. Air goes out the valve, and then a seal has to be made so that you have a closed system. So that's the general concept. You'll see on each of these slides too, there are pros and cons. So these are easy to don and doff for the most part, and they're pretty comfortable. Patients like suction a lot in the transtib level. The cons, they're sweaty, but most of these are sweaty anyway, just because they have a liner. And they use this other piece called a sleeve. So I don't have a particular slide about the sleeve, but I have one to demo to you here. So a sleeve is used specifically for the suction system in the transfem level amputee. So it is also a gel sleeve that goes over the top of the liner. This particular one has a fabric component, and that goes over the ears of the socket. It's kind of a reinforcement. This is the weak spot. This is where the sleeve will get a hole in it. Then you take the leg in the liner, it goes down in the socket, air is pushed out, then you roll the sleeve up over the whole thing. The whole trick here is that you need to have a significant amount, and by that I mean at least 2 or 3 inches of sleeve on skin above the liner. That's your closed system for suction. Air can't get in, air can't get out. Patient takes a few steps, that forces the rest of the air out of the one-way valve. Boom, you have your suction suspension. So that's the general concept. Now you can imagine this creates difficulty with hand dexterity. The other thing about it is now you've got some at least 3 millimeters of material of thickness in the liner behind the knee in the popliteal space. You add another 3 millimeters with the sleeve. People can't bend their knee as much as they would like. So that's another one of the drawbacks for that particular system. That said, it's still a lot easier to don than other ones that I'll show you. Okay, that's the story on the suction. Now, pin lock. This, when I started practicing over 20 years ago, this was the most popular that I saw all the time. It was before the suction system was really going well and used traditionally. So this liner for the suction system is called a cushion liner. This liner for the pin lock system is called a locking liner. It has this really kind of rigid umbrella, plastic umbrella. When the patient is donning this, they need to roll it. I talked to you about turning it inside out all the way to the umbrella, so that again we try to avoid any gaps, any areas where we're going to add increased pressure. So I like this picture on this slide because it shows the pin going in. People like this because of the security. I heard the clicks Therefore, I know my leg is on. It's like a belt and suspenders. People really want to know that that thing isn't going anywhere. So one of the benefits too is that then you don't have the sleeve and it's not so bulky. So here's what it should sound like. So you get a ratcheting sound as the pin goes into the lock. Now, here's one of the cons. This is a button on the medial aspect, and the patient has to bend over and mash the button to be able to unlock it and pull the liner out. Now, this button could be put in other places depending on the patient's mobility. But a lot of these folks who are less mobile, leaning all the way over, finding this button, pushing the button with one hand, and then sliding the prosthesis off can be a little tricky for them. Also, you don't get the best volume management. So you do use socks with this system just like you do with the other systems, but you might find that there's still more pressure at the very end where the pin is, at the end of the distal end of their residual limb, if they're not managing their socks correctly. And that you can also get a little pistoning in there, in the pin lock. So you may or may not see that. We don't do that many of them anymore, but they are the right thing for the right patient. And that's, again, a great conversation with the prosthetist. So between the two systems I've talked about already, you can see how you as a therapist, even before your patient gets a prosthesis, you can contribute to that conversation of what suspension system might be the best for them. Because you know what their manual dexterity is, you know what their cognitive processing is, you know what their mobility is, their balance, their sitting balance, all of those things. So you might be able to contribute to that discussion and say, wow, I really don't know that a pin lock is going to work for my patient because ... or vice versa. Maybe the suction won't work for them for reasons that you've noticed. An example, I had a patient some years ago with pretty significant diabetic neuropathy in his hands. So a lot of muscle wasting in the lumbricals. And he had a lot of difficulty managing sleeves. So I had to go back to the prosthetist and talk about other options for him. Okay, partial suction. You may see this occasionally. Again, talk to the prosthetist to see what they like. So there are different kinds of suction liners. So this one has a series of rings on it that are incorporated into the liner. And the concept here, you still have a one-way valve, just like you have with the full suction, but you only have suction from the bottom ring down on the bottom section, right? So you're going to push in, it'll expel the air through the one-way valve, and your suction is just from here down. That's why some of the prosthetists don't really like this for transtib and prefer full suction all around the whole residual limb instead. However, another benefit of this is you don't have a sleeve, so it's less bulky posteriorly. You also might have, this is a larger liner, this is for a transfem, but I brought this to show for both. You also might have a separate ring and just one ring that is adjustable on where it is on the leg, on the residual limb, in order to get the most suction. One of the tricky parts, I think, with the partial suction is teaching the patient sock management. The sock can't go over this ring, or it's a wick, it's an air wick, and now you've lost your suction. So you can have half socks that go distal to the ring, or half socks that go proximal if they're getting a lot of motion proximal to the suction, the point of suction. So there are a couple of things about that make it tricky. I know I'm beating this to death, but definitely talk to your local practitioners about when they would use what and why, especially if you have a particular patient in mind. Now we're moving on to the transfem level. So the classic one that a lot of you will see is the lanyard. So again, this is a locking liner with a lanyard strap on the end of it instead of the pin. That's really the biggest difference. So the tricky part here, I like the pictures on this slide because it shows stepwise what the person has to do. We put this person in a clear socket. They have to put the liner on, feed the strap all the way through the hole at the bottom of the socket. Then they have to be able to lean over and pull this strap toward them and then hook it through and then strap it back down to itself. So it's a Velcro strap. So you have to have a fair amount of mobility and dexterity, and you got to figure out exactly where that hole is in order to feed the strap through. So those are some challenges. However, for the pros, for the people who are able to don this, it's pretty secure. People know it's on and it's not going anywhere. And you might have a little rotation on the socket might rotate on the patient if they're losing girth of their residual limb, but the lanyard reduces some of that because it can't go very far. So that's one of the benefits of this. You can use regular socks also with the lanyard, which I think really allows you to adjust for the size of the residual limb. Okay, pin lock. You might notice on this slide that we say we can't find your file, and that's because our company rarely does a pin lock for a transfem patient. So we didn't really have any people available to take pictures of. That said, there's a new system. You might see a separate presentation about the Connect TF system, which is a different kind of socket, and it does use a pin for a transfem patient. Otherwise, we really don't do it. But that said, you might find that your local prosthetist might have a reason why they will do it for a particular patient. The problem that I've seen years ago when it was pretty common is that when people are donning that liner, having that pin pointing up or pointing down, really common. And that's true also for the trans tib folks. So they would put the liner on. They couldn't really tell where the pin was. They try to get the pin in the hole in the socket. They're all over the place. So a drawback also for this system and for the lanyard is when you are seated, the limb is only partially on your leg. You'll slide the pin lock on and you'll get a click. You'll pull the lanyard through most of the way. Then you stand up, you get all of your body weight through the leg that goes all the way to the bottom of the socket where it's supposed to be. Then you hear more ratchets on the pin lock, or you strap the lanyard down a little bit more assertively to make sure that you're all the way down in the socket. So the lanyard you're going to see on lower level patients, maybe K1, K2 patients, they need to be able to adjust that when they're standing, which might be a little tricky for them. All of this stuff is great for our training and therapy. Absolutely. Okay. Now you can have suction for the transfem patient, and that's really where this comes in that I showed you. So same kind of concept where you're going to have suction below the ring, but because they're transfem, you can't really have a sleeve. There's really no way to get a closed system that works really well for the transfem because of the location of the top of the socket. It's going to gap a little bit. You can't stop that. So this is usually you're going to see this on a higher level patient, and they need to be a little bit more stable in their limb volume. When they shrink, they lose suction, and they need to add socks, but losing suction, it can be a real problem, more so for the transfem patient, I think, than for the trans tib patient. So here's what's interesting about the about the transfem patient for the suction. So they also have a valve. And this valve, they'll don the socket, they'll stand up and push, and every time they put some body weight on that leg, they mash. There's a little button right in the middle. They mash the button, it lets air out. It's still a one-way valve. They release. They put body weight on it, they mash the button, release some air, and they do that a couple of times until they really feel the suction is great. For us, for therapists, and also for the patient, if they can't tell if they're already all the way down in the socket, when they're standing, you can remove this valve. Now you have a window. You can look in there and see, are they all the way down in there? You can reach your finger in there. Is there any space? The patient can do the same thing. If they're comfortable in standing, they have to have their body weight on the leg. They're going to reach over, take this off, reach in. Am I all the way down in there? This is early in their rehab when they're learning what it should feel like to have the socket donned correctly. Then they put the valve back on. Now they have to reestablish suction. When you take the valve out, you lose your suction. Put the valve back in, put some body weight on, release, and you're good to go. That is kind of handy, I think, for us as therapists to know exactly where somebody is in their socket. A little tip for you, these things are expensive, and for your patients. They're only going to get one. They're a few $100. If they lose this thing, one of my patients had one fly across the room, and I don't know if his dog ate it. I can't remember what happened to it, but he could not find it to save his life. So they're expensive. Let your patients know. As soon as you take off the socket, in order to doff the socket, you take the valve out, break suction, you pull out, put the valve back in right away so you don't lose track of it. So that's suction for the transfem patient. That kind of gives you your overview. I know this was a little quick, but I feel like the majority of what I've talked about is also on the handout on the slides. So you can go back and review when you have a patient in front of you. And obviously, if I've raised any questions that I haven't answered, please talk to your local team about it. So I'm going to give you a few general donning tips. This is big picture stuff across the board. Again, for you OTs out there, perfect thing for you to be working on as well for our patients. So this kind of works them through what should happen. They slide the socket onto their leg. We've talked about that in a couple different ways. Snug is what you're looking for. They should have a good snug feeling. It shouldn't feel too tight, but it shouldn't be loose enough that they can feel pressure points. Obviously, for the transtib patient, the most common pressure point is going to be the distal tibia. You'll see other pressure points as well, but that's the most common one. For the transfem, it's rarely bony prominence because of the soft tissue. Obviously, it depends on the shape of somebody's limb. So if the socket is too loose, then it means that they're going to, we call it crashing into the socket. They're going to fall down to the bottom of the socket, and they'll have focused pain, possibly red skin. Non-blanchable erythema is the big problem on the distal end of their residual limb. I always start a therapy session, especially early on in their rehab, with them doffing their leg, and then I can see how things are going. Number one, I'm looking to see if they know how to do it correctly, but I'm also taking a look at the health of their residual limb so that I can give them some points about whether or not they need to add socks, etc. So how to adjust the socks. This kind of gives you the overview, and you might have your own sock management handout for patients. I would suggest that you get the handout from your local provider, because the patient comes to you for their outpatient therapy session, and you say, what did they teach you? And they say, I don't remember. And well, what about your handout? I left it at home. Here it is. I happen to have one. But because you're going to be reinforcing what the prosthetist told them, and you want to make sure that you don't throw them for a loop, and you guys are really speaking the same language. I think that's really important. So I mentioned most of these points already. You might need to adjust the number of socks throughout the course of the day. I like to tell patients early on, you need to have a sock or two in your pocket when you're leaving the house, because you do not know when you're going to need socks for the first several months. It can take up to 2 years for the volume of a limb to stabilize so that somebody doesn't need to add socks anymore. And by then they've got at least one new socket, or maybe a second new socket. You can also, even for a regular cushion liner for a suction, you could cut a sock in half. If somebody has too much room distally, but they're fine proximally, especially at the knee, maybe where the socket is really snug against their against the sides, the lateral and medial aspect of the knee, but they're flopping around distally, you can cut a sock in half and fill up that space, and that often makes people a little bit more comfortable. So that's an extra little tip. How to know if the prosthesis is on correctly. I find this to be really helpful for us as therapists. It took me years to learn this, so I want you to know it right now. So where the patella is, this is specifically for trans-tib patients. This is the way our prosthetists make these legs. You, again, want to double check with your local practitioner. So if the patient is sitting with this prosthesis, there should be about a 1/4 inch from the brim of the socket to the distal aspect of their patella in sitting. Then when they stand, that's reduced there, but we don't want their patella hitting the brim. It needs to be just proximal to it. Imagine how much painful that would be, how much pain you would have if your knee kept whacking into the brim of that socket, which could happen if you're not wearing enough socks. Not wearing enough socks, your leg has shrunk, you fall down. Some patients, that's where their primary pain is going to be. Oh, it hurts right here on my kneecap. That tells you probably need to add a sock. You're falling down too far. Make sure you would look at that, and again, let the prosthetist know what you found. If they are too far above, if they wear too many socks, they're going to be up here somewhere. And if you think about this being a custom socket, so this one has a nice relief here that was put in for the distal tib of this patient. If the patient is too high in this socket, where this relief was, now that bony place is up here, and it really hurts because it's not matching where the relief is in the socket. People tend to think early on, socks provide cushion. Therefore, if I have pain, I need more cushion. Therefore, I will add more socks. And then they kind of go crazy and they end up all over the place. And sometimes the answer, instead of adding socks, is to take socks away. I have run into that on several occasions with patients, and I've missed the boat, and the prosthetist had to call me up and say, hey, this is what's going on. Also, I said at the beginning of an appointment, I'll have the patient doff and don their leg again. If that leg comes off really easily and goes on really easily, then I start to be concerned that they need to add socks, or there's too much room in there. Another thing, in sitting, if like they're sitting, their knee is at 90 or a little bit less, if there's a big gap, so I treat it almost like a dog collar, where you're supposed to be able to put 2 fingers under a dog collar and that's loose enough. If I can put 2 fingers in there, I know we're okay. If I can put my whole hand, or I'll joke with the patient, if I can put a whole sandwich in there, they need to add a sock. There is something going on with the fit. So that is some observation and some instruction as you go along. So those are a couple of different ways that I can tell generally if they're in the right place in the socket. And then, of course, taking off the liner. Do you have any red spots? I touch all the bony prominences, anything sore. That's another way to double check. For the transfem patient, are they all the way down in the socket? I mentioned already that you can take out this valve to see. So we went through that. Ease of donning, the same story. If it slips right on, that might be too big for them. If you can put your hand down in there, or a sandwich, there's too much room. The other thing for a traditional ischial containment socket is if they do not have good ischial containment. And you're going to be able to tell that in standing if there's a really big gap, or if you try to, if you pull on the lateral aspect of their socket in standing and it comes away from their leg, and again, you've got a whole bunch of room in there, then they probably are, they're too small. They need to add socks, or the socket needs to be padded in some way to tighten it up a little bit. If you grab that lateral border and pull a little bit and it's nice and snug, then they have good containment and you're probably okay. So there are several ways to know if the socket is on correctly from a girth perspective. For the transfem patient also, the sockets are made so intimately that if it's rotated the tiniest little bit, if it's an ischial containment socket, it's rotated, the patient will know. It's going to poke them in a place they don't want to be poked, and that's typically rotation. Now, if they don't have enough socks on, they're walking, could the socket rotate a little bit in the course of walking, and then they say it's poking them, and that kind of gives you a clue that they need to snug up that fit a little bit to maintain the right placement of the socket on their leg. Tips for managing perspiration. It took me forever to learn this too. I love these tips. So many of our patients struggle with this. So I already talked about the sheath or the liner. Liner is a method for managing perspiration. There are also over-the-counter deodorants that are clinical strength now that patients can use. Make sure you read the instructions. Some of them want you to apply them the night before. So they manage the size of your pores. So Certain Dry is one. And again, these are available now over the counter. Crystal is also one that is a natural product. So have the patient try applying it the night before. You can then in the morning, you can shower if you want to, and it shouldn't affect that. And then try to don their liner, or have them try to do it in the morning and play around with it and see what seems to work. There's also a newer product made by Alps. Alps is a company that makes prosthetic liners, and it's called Prosthetic Antiperspirant Spray. So it's just a spray that you spray on your limb a couple minutes before you're going to don your leg. You let it dry, and then you go ahead and put your leg on. We've had some patients have some moderate success with using that particular product as well. And these are also available online. What to do when the patient's not wearing their prosthesis? So they should be wearing their shrinkers, especially early on. And by early on, I mean 6 months at least. When they're not wearing their leg at night, they wear their shrinker. So I didn't talk about not wearing these at night. Please, patient, never wear your liner at night. So they wear these during the day when they have their leg on. If they're early in the process where they're wearing their leg a couple hours, then taking it off, putting it back on during the day, they can leave their liners on, maintaining the size of their leg. This is great shrinking right here. But at night, they always take it all off and they put on their soft shrinker. That's what they should be doing at night. Some people years out from their amputation still wear a shrinker at night because it gives them a sense of security. What you don't want is that they're not wearing a shrinker at night. They can, if they swell up in the middle of the night, which can happen for amputees depending on other medical conditions, then they can't get in their socket in the morning, and that's not cool. Also on this slide, it talks about how to clean your liners. Patients always get two. They should wash one, wear the other one. And they also get specific instructions from the prosthetist about how to clean them. If a patient's skin is looking problematic, it's almost always a hygiene issue more so than a true reaction to the material in the liner. That material is inert. So either they're not washing their skin well, or they're not washing the liner well, or both, or maybe they need to use some kind of lotion at night as well. Great topic to talk to the prosthetist about as well. You can tell what my theme is. Talk to the prosthetist. That's all that I have for you today in this presentation. I hope it's helpful for you. That's given you some ideas, a little bit more specific insight to help your patients. So now I'll turn it over to your local team for any questions you might have. Thank you so much for attending.